This
very
conference
robustly
will
and
now be
extensively.
recorded.
Am I audible?
Yes, sir. Yes,
Okay.
sir, you are audible.
So yes. So the topic that has been given to me, that is electrophysiology, and I have been a part of this core electrophysiological family here in LB Prasad in past 8 years or so. So just you would all agree with me that it is not, it is almost impossible or near impossible to explain this all slides in only a 60 minutes time, and we already have missed some moments. So I just let you know what are the prerequisite knowledge you should have before you should interpret electrophysiological test. So usually that electrophysiology starts from it is a electrical potential, that is a kind of a visual electrophysiology, and everything is related to function. That means in ideally in your day-to-day practice that you all are dealing with, that is the structural equivalent. So there is a no functional status. So to identify the functional status, you must seek help of the electrophysiology. So it is a robust test that would help you to idealize how the health of your neurosensory part of your eye. So these are the basic components in that slide that comes from the retina and ended up to the visual cortex, and in between then every step these are the components. uh, Importance of these electrophysiology. Remember that my presentation is not related to ERG only, that is, you know, that electroretinogram. But no matter what is ERG, what does it do, I would also convey a message to all of you that how the electrophysiology would work in that form of ERG, VP, OG, and so on. So it allows you to understand the extent of the retinal diseases. There are numerous diseases, retinal diseases, which could mimic like a same disease, same pathway, but can be segregated. And amount of vascular pathology, how long does the pathology extend, or in which layer of the neurosensory part is affected, that would allow you to understand. And along with that, you must look for the reproducibility of the test. That means once you proceed for the test, you have seen a response, and another time if you are doing the same process, if that does not match with the previous record, that means it is not repeatable. So these all are important aspects where we seek help from the electrophysiological status. So couple of important potential languages you should keep in mind. You can note it down, or you can later on ask me. I can share the articles or some PDFs. So these all are the abbreviated forms, like membrane potential, action potential, standing potential, and subsequent slide I have a couple of more. So membrane potential is the difference between the electrical exchange or the electrical potential of a cell, and that differs from outside and inside of the particular cell body. So in usual stage, while a person is resting in a dark room, that is kind of a resting potential, that is a static membrane potential. So what is membrane potential then? That is the difference between the exchange of the retinal potential or the electric potential of the retina within the surface of the retina, outer as well as inner. That is the difference. Then action potential, what is it then? It is a membrane potential of a specific cell location that rises and falls. So while you see any electrophysiological test or graphs, the remember the potential change of that graphical representation that you see, that is action potential. So we have to measure the action potential. Otherwise, if a patient is in a dark room, it is not possible to idealize the action potential, because that is in the resting potential. Then standing potential is the difference of the potential of anterior and posterior part of the eye, which is done by electro-oculogram. Okay, and I would request to all of you, if you have any doubt, please note down and let us know, so that we can conclude that with a good resolution. Otherwise, it would be tough for me to understand how many of you are getting me. Is it okay?
Yeah, sir.
Yes, please note down your queries, because within this span, I just describe this all, and at the end, if time permits, we can discuss this, interact this little bit, or else if time does not permit, so you can mail me. I have shared my mail address, then we can interrogate. And the transepithelial potential is also a kind of a standing potential that is being measured by the electro-oculogram. And electro-oculogram is the to know the status of the retinal pigment epithelium. I will describe this in my subsequent slides. So this is the basic cartoon of a retinal layers. That is in our undergrad level. We have seen a lot of cartoons like that, schematic views of the retinal layers. So here it is important that how do you imagine yourself as how the retina reacts, and how can you incorporate this to in your professional goal. So in this slide, try to imagine that you already have seen, means India and Nepal is not far, and it is obvious that you all have seen a dish TV which is situated at our rooftop, that takes the signal from the satellite, and that transmits the signal to our television, and that makes us to see TV that we all see in daily basis. So in our imagination, our eye acts as a dish TV that takes imparts a signal. Am I audible?
Yes, sir.
Yes. So how eye is acting, it takes a signal from the satellite, just like a satellite from the visual stimulus, and it transmits the visual signal to the brain, and that is how we see. So that is the good momentum for eye and brain coordination that makes us to view any object or anything else. So it is not provoking you to smoke. This slide tells that how a normal cigarette looks and how a wet cigarette looks. So in my left hand side, it is of a normal cigarette, how it looks, and in my right hand side, it is a completely wet cigarette, so that you can see the masala inside the cigarette. So your retina looks like same, the neurosensory layers look like same, like this white part, and the pigmented masala inside the paper is the retinal
So can
pigment
it
epithelium. Hello?
unknown from the unknown device? It was coming so noise. So wait for a minute. I'll be unmuting.
Yes, better to keep the device on mute mode, so that we can avoid a further noise. Is it okay now?
Yes, sir. Now it's good.
Okay. So idea of this slide is to show that how our retina looks, because we all know that retina is transparent. So this right hand side, the wet cigarette looks like the neurosensory layers, and the pigmented masala is the retinal pigment epithelium. And this cartoon shows the how signal comes to the retinal surface, that you can Google it and can see the how this chemistry works. So I'm just going to the details of my core topic here. So remember, we have two important parameters of cells. Parameters of cells means these cells take the signal from the photoreceptor and helps us them to pass to the inner retinal layers, and from inner retinal layers to the brain. So the bipolars and ganglions are two identical cells that is acting as smart as it is. So the receptive field of a cell means that acting potential of that particular cell. So the receptive field of those bipolars and ganglions are of two types. One is on cell, another is off cell. So now focus onto the slide here, which is being shown now. On is if that on is at the center and off is at the periphery, if light falls on the on segment, so the action potential gets the peak. See the depolarization here, it is written as a depolarization, but it just reverses if that comes as an opposite side. If light falls at the periphery, like in the off side, so it degrades down. So that is known as the hyperpolarization. Same thing, but in opposite phenomenon that happens while light falls at the center, if that means if it is the off cell, and if light falls at the periphery of that off cell, that means at the on cell. So the summary of this slide is, if the light falls at the center of an on cell means center is positively ion and periphery is negatively charged. Off cell means center is negatively charged and periphery is positively charged. So if light falls at the center of an on cell, so it gets the peak. But if light falls at the center of an off cell, so that means center is already off, so it is negatively charged. That shows the hyperpolarization of an wave. Just in opposite the keeping in mind the principle remains same like this, but principle just reversed in other, translated in other way. See the ganglion cell on area, if the center, when the light falls at the center, it induces more number of frequency. But if light falls at the center of an all off centric ganglion, when the center is off mediated, so the frequency becomes inhibited. If that is well understandable, that is good. If not, then you just remind me, I'll explain it in my in briefly, as good as long as you don't understand. So you know that how a vitamin A plays an important role in phototransduction. So in our undergraduation level, you all have read that how vitamin A is helping to form a rhodopsin, and that induces the light induced changes. So this is the rhodopsin bleaching. This slide shows that how rhodopsin gets bleached, and this is the cycle when the vision is getting accomplished. So our eye surface is considered to be a battery while the cornea is acting as a positively ion and retina is acting as a negatively ion. So this is the corneoretinal potential that is always on, that is always turned on if it is in the resting stage or it is in the action stage. These are the two photoreceptors. One is rod, another is cone. Rod is known as a rod spherules and cone is known as a cone pedicles. So and these are the two surfaces, inner and outer surfaces. So the inner surface that contains the nuclei of the photoreceptors, and outer surface that contains the disc of the photoreceptor or the tail of the photoreceptors. Along with that, there are inner retinal cells which always make some synaptic junction with the photoreceptor and helps the signal to pass through to the brain. And in between these inner retinal surfaces, there are some sandwich cells which are acting as a junction, just like amacrine cells or the horizontal cells, and as well as the bipolar cells. That acts as a mechanism to transmit the or to function the two cellular reaction. For an example, if I am talking with Kapil here, what is my mediator? My mediator here is either air or this telephone. Then this phone, we can communicate our language. So if there is no air or there is no telephone or the smartphone or any electronic gadget that does not allow you to speak, then we cannot. So these horizontal cells and these amacrine cells are acting like to make the mechanism of the cellular transmission. So in our day-to-day practice in electrophysiological lab, it is always important to know which process to choose. So in which direction to go. There are numerous procedures. So if a patient has come to you, you should perceive, or you have to use your perceptual theory that which and so on and so forth. So we have a network, universal network, that is known as the ISCEV. That is a standard, that is the International Society for Clinical Electrophysiology of Vision. That helps you to suggest which test to choose. So if pathology is in the retina, and you are quite confirmed, so you can proceed to perform an ERG. If pathology is in the prechiasmatic layer but away from the behind the retina, so you should apply your concept to use the visual evoked potential. So I say always there to help you all the time. So there is a guideline, and that guideline gets changed every yearly. So it since 2005 ISCEV is standardized, and until 2018 it is last updated. So we have frequent options. Now I am gradually switching to the electroretinogram. So there are options: full field flash ERG, pattern ERG, focal ERG, and multifocal ERG. So ERG is basically electroretinogram. So name itself helps you to understand that is helping you to get the action potential of your retina, and not only the whole retina, but also you can segregate which layer the pathology is situated, or which part of the retina is affected. So full field flash ERG is a gross or global ERG. So it gives you the overall response. So suppose if you ask me to answer me that what is the average age of those participants who are here today, so what I should do, I should calculate I would sum of your age, and then I should subtract the amount of number of participants here. If that comes around 25, so that is the overall response. So it's an overall age of these participants are 25. So now, if among you there is someone who is 70-year-old, okay, so out of this 60 or 70 participants, just take it in a way that there is someone who is 70-year-old. So now if I make this average, that 25 would switch to 27 or 29 or 30. So that does not justify my answer whether I can focus on to the person who is 70-year-old. So because we are averaging the overall response of that participants. So to idealize the 70-year-old participant, what I should do, I should perform a focal ERG, or the multifocal ERG. So that to channelize me what is the overall age. It is not the overall average of that age. Overall age means I can go up at the top and can see who all are 25, who all are 26, who all are 70, who all are 50. So then in that, at the end, I can summarize that, okay, there is a 70-year-old, there is a 25-year-old, there is a 22-year-old, and so on and so forth. So these are the strategies being used. So these are the full field flash ERG protocol that gives you overall response. Pattern ERG, that is a kind of a focal response that I'll show you later. And simultaneously, I'll briefly describe that how multifocal ERG looks. So overall, there are some electrodes. Remember, without any help of electrode, you cannot get a record of the action potential of your retina, because these electrodes are helping you to get connected from your eye and as well as the machine. So machine needs something to get connected with you. So you know that how these tests are done. So if you are performing an OCT, what is that intermediator? That is infrared light. While you are performing ultrasound, what is the intermediator? That is probe and the gel. And in ERG or in electrophysiological test, we have an intermediator, that is the electrodes. So these are the series of electrodes that can be used. You can Google, or you can go to some articles and can see what are those electrodes and how these are being used. So this is very important to place a patient properly, explain in their own language that how the test is being done. Otherwise, if you do not make the patient understand, your test can go waste. And you need three type of electrodes. A type means that should act as a positive, should act as a negative, and can act as a ground. So there is no specific electrode in ERG that could act as positive or can ground. You should put in a row in a junction box. You should put in your junction box plus channel, minus channel, and ground channel. So if you put your electrode on a plus channel, that electrode would act as a positive electrode. If you put your electrode on a ground channel, that would act as a ground electrode. So these are the instrument. This is the instrument the overall look of an instrument of ERG that gets changed from machine to machine, company to company. So in our campus, we have this latest version of MetroVision. This is a VERIS system. You may have seen VERIS itself is a VRIS, Visually Evoked Response Imaging System. And this is the current model that we have in our campus. So that I have discussed in my previous slides, these all models are tabletop models. So it is not possible to perform if a patient is in the supine position, or if a patient is in operating theater, or if a person is not cooperative, or a pediatric age group, a type of patient of pediatric age group. So that time we should use some advanced technology. So we have also a tabletop instrument that can also be used in a daily basis, and this machine is applicable in those scenarios that I have just discussed. Electrode placement is pretty easy, but you should keep in mind that how to place it. So there are ways which type of electrodes you are using. So you have a DTL or ZERI electrode, that ZERI which was invented here in LV Prasad back in 1992, I guess, if I'm not wrong. But DTL is, but ZERI electrode is not ISCEV standardized electrode, but DTL does. There are numerous type of electrodes. It has its own pros and cons. It has its own style to place. So remember which type of electrode you are choosing. Currently, the slide which is you are seeing viewing, that is the ZERI electrode. It is a jet electrode, and the process, the style of placement of a Boolean Allen electrode is also same. So you should patch one eye, and you should use a contact lens electrode. So remember, while you are putting this, you should explain the patient that you are about to put a contact lens type of electrode, and use a tear solution at the inner surface of the contact lens, so that interaction between the contact lens and the cornea would be good. Otherwise, if you do not put that tear solution, so the lens may pop out in between the test. So that would create, you will be in trouble and your patient will be in trouble. So the patient preparation is again important task that is directed by the ISCEV, that a patient should be fully dilated. If you are aiming for a full field flash ERG, then you should give a sufficient adaptation time. If a patient would have had a test like FFA or OCT done earlier than the ERG is performed, then you should again ask the patient to sit in a dark room for next 2 hours or so, because as you have used a very dense flashlight, then that is what your rods are completely bleached. So this is the way of an echograph, that response that is being seen. It is important again to understand how do you measure the amplitude and how do you measure the implicit time. For the sake of my time, I'm not going to the details of this management of this measuring part. just remember that amplitude gets started from the baseline to the trough and from trough to the peak, and time gets always started from the baseline to the trough and the baseline to the peak. So as per ISCEV standard, there are 5 subsets of tests being done out of the 2 segments. One is scotopic, that means in the dark stage, and one is the photopic, that is in the light stage. In the scotopic, we are more towards to assess the photoreceptor rods, and in photopic, we are more towards to assess the cones. And simultaneously in oscillatory potential, we look for the amacrine cell function. So this amacrine cell function can be switched to the photopic segment also, but as ISCEV has already mentioned, that is in the scotopic, so ideally we do in the scotopic part. So this is the first segment that comes under the scotopic part, that is isolated rod response, or the scotopic 0.0. It does not have A wave, but it gives a broad B wave. Why it does not show A wave? Because your photoreceptor does not get affected with that minimal amount of light, because while you start getting the action potential, you should always start from the very minimum light. So ideally I just give one theory that you have seen or you have read in your undergrad level, but just to recapitulate that, in a dark room, while you are situated in a dark room, if you are there since a longer time, so you start using your rods, or no longer your cones will be excited. So if you try to focus some objects, you have to view your eccentricity to see an object. So you already have seen that while you stay in the dark room for a long time. So what happens, that is the resting potential. What happens that time? Because in a dark room, among the photoreceptor, there is always an exchange between plus ions and minus ions. Plus means, just for an example, sodium, and minus means OH minus or Cl minus, kind of. So while you induce a light, the gateway between the photoreceptor inside the photoreceptor is closed. So there is no longer the exchange can take place. So what happens in this time? Your plus ions comes out from the photoreceptor and goes inside the in the inner retinal surface in order to make a bond with the negatively ionized cells. So your photoreceptor will become a negatively charged cell in that time. That is what your eye is acting as a battery in normal workable condition, because your photoreceptor will be negatively charged and your cornea is positively charged. So that all happens while you induce a light. So that does not come over time. So we have to start from very minimum light and then switch to the maximum intense light. So once you give a minimum light, so your photoreceptor rods are not fully charged. So that is what there is no A wave. A comes from the photoreceptor and B from the inner retinal response. So here the photoreceptor induced, that means a rod induced inner you cannot able to see that inactivated photoreceptors or rods. So you can see that activated photoreceptors, and which is coming from the photoreceptor rods and partially from cones. And the B wave here is the on bipolar cells. So in my previous slides, I have discussed that how your on bipolar cells are. So on bipolar cells are when the center is positively charged and periphery is negatively charged. So this is highlighted here in the maximum combined response. Simultaneously, amacrine cell response is seen while you use that application of oscillatory potential. So if your retina is purely ischemic or inner retina is not functioning well, so you can see two uh, overviews. One is your B wave of your maximum combined would not be well formed, and next is your oscillatory potential will not be present, or if it is present, will not be that highest that we usually see. Now you make the patient sit in the lighted room for 10 minutes and then switch to start using your cone mediated protocol, that is a single cone response. That is the style of the this waveform looks like this. So A from the photoreceptor cones and from off bipolar cells. Off bipolar cells are those cells which are negatively charged at the positive and positively charged at the periphery. So, and the inner retinal potentials, that B wave comes from the inner retinal cells. So cone induced response is coming from the B wave. So I already told in ERG, A wave comes from the photoreceptor and B wave comes from the inner retinal cells. So here inner retinal cells is cone mediated inner retinal cells. So in isolated rod, what exactly happened? Inner retinal response, which is mediated by your rods. In maximum combined response, inner retinal response maximized by the photoreceptor rods and partially from cones. Here we are getting the information that inner retinal response from your cone cells. And last, it is also equally important that 30 Hz flicker that uses flickering response, that in per second that machine itself flickers 30 times. So your rods are completely bleached. So you are only seeing your cone function of your cones. So in view of the cone pathway, if there is a damage in the cone pathway, your this type of response would be completely absent or partially present, or not as good as how the normal waveform looks. So this is the normal overview of the overall flash ERG. This is the overall view. That differs from machine to machine. The style may not change much, but the shape or the pattern may deviate a little. That is what ISCEV always says, that you should have your own normative data, no matter which background you're in. If you are in India, if you are in Nepal, if you are in Bangladesh, or if you are in Nepal, if you have labs in different setup, you must have your own normative data, because you may be seeing a different type of people there in one setup and different type of people in another setup. So is being used, keeping in mind if the two setups are very close by, but one setup is using Boolean Allen electrode and another setup is using a DTL electrode. So you must have your own normative data, because DTL electrode gives less response compared to Boolean Allen electrode, because Boolean Allen conforms over cornea, but DTL electrode situates away from the cornea. This is how a negative ERG looks. So you have negative ERG is when your B wave is lesser than the height of your A wave. So in my left hand column, you see that your B wave is longer than your A wave, but in my right hand side, where it is written that a 49-year-old man, you see that waveform, B waveform, is not as high as A, and overall it is lesser than the A wave. So that is known as the negative ERG, and negative ERG is seen while you perform maximum combined response under the scotopic stage. So there are cases while you can see that negative ERG. First is congenital stationary night blindness, X-linked retinal schisis, melanoma-associated retinopathy, CRAO, CRVO, diabetic-induced retinopathy, or Oguchi disease. In those scenarios, these are the names of where you can find that negative ERG. Idea is to remember these diseases is to, while a patient has come to you and suspected case of these that I have explained. So you have to focus on the retinal negative ERG on full field flash ERG to see how the inner retinal retina is acting. So negative ERG means your inner retina is not proactive. So your photoreceptor may be sending the impulse, but it is not getting properly utilized in your inner retina. So am I clear till now, or am I still connected?
Yes, sir.
Okay. So
after the session, we have a discussion session. So yes, sir. After the presentation, we have a discussion session. If anybody have the queries, they will be inbox on the chat box, and we'll be discussing on the discussion session, sir.
Oh, sure. That is good. That is good. So idea for keeping the presentation on hold here, because I am just about to switch to pattern ERG, but as I already have discussed more about full field flash ERG. So pattern ERG is basically done to look for the macular health and as well as to look for the ganglion cells. So there are three components, three parameters to understand or to look for. One is N35, which is N means negative, P means positive, N35, P50, and N95. So 35, 50, and 95, these all are the parameters, and that justifies the implicit time. So N35 should be within 35 millisecond, so should be formed within 35 millisecond. 50 should be within 50, and 95 would be around 95 millisecond. It does not mean that it should always be at 50 millisecond or 95 millisecond, but overall it should be around 50 or 55 or 45 or around 90 to 92 or around 100, but it should not go longer than that. So P50 is from the macular photoreceptor and N95 is from the ganglion cells. So N35 it is postulated that N35 is coming from the retinal pigment epithelium, but we do not focus on N35 here on pattern ERG, because we already have a protocol to justify this N35 from electro-oculogram. So ideally we have to focus onto the implicit time, as well as we have to see the amplitude either, and we have to correlate how our normative data stands for. I forgot to remind you that as you must have your own normative data, you should also have your age matched normative data. Age matched normative data, that means if you have a patient of 50-year-old and you have your normative data among 20 to 30 years of age, that may not match, because we all know that as our accommodative stimulus is getting deactivated as age progresses, so your retinal stimulation or activation or potential affection will also reduce if age progresses. So if you are about to compare your data of a 51 or 52-year-old patient, you have to have a data of that age group, let's say 40 to 50 to 60 years of age, and that is how you can have your own comparative data. So it is a good summary. While you get into this, it is always a good to summarize when to choose which test. So it is always getting started from your pattern ERG. While from pattern ERG, because pattern ERG does not require your pupil to be dilated, so it is always done in undilated stage. So you have, because if you have a patient with dilated pupil, so you cannot do anything because pupil is already dilated. But if you have undilated patient, you can at least idealize what to do before getting the pupil dilated. So this is a good summary. You can take a snapshot, or you can ask me, I can share, or most of you would have had. I guess Gautam already have taken a class, and he may have that document with him, so we can have a better interaction. If he has, he can share. If you ask me, I can share. But it is good to have this summarized part of this, which test to choose if you have a patient with undilated pupil. Now, while you are summarizing overall response, you go for the full field flash ERG because it gives you an idea of your global response. But if you are focusing onto the focal change, let's say your macula is affected but periphery is unaffected or spared, or periphery is affected, macula is spared, then it is always good to see the focal change with the help of multifocal ERG. So multifocal ERG is developed by Dr. Eric in 1991. It is good matched while to look for bipolar cells as well as ganglion cells. It is calculated in this way. It is known as a M sequence or pseudo-random sequence. First sequence is the first order kernel, which is termed as A, which is good for bipolar cells, and second order kernel is termed as the B, which is good for your ganglion cells. So if time permits, or if you ask me later on, I can discuss more on this first order and second order kernel. You just what you have to do, you have to remind me at the end of the presentation. Then overall multifocal ERG looks like this. It is black and white checks, and it could be more congested at the center, it could be evenly distributed. If it is more congested at the center, which is being used regularly, that is because the more cones are densely packed at the center. That is what at the very top corner photograph shows that black and white hexagons are mostly congested at the center. And overall deviation of the stimulus pattern, it is shown in the 3D diagram as well as in the form of trace arrays. Then you have to see that you have to network in a way that which area you have to focus, whether you should focus at the periphery or at the center or at the particular quadrant. Remember, while you see a multifocal electroretinogram, it is always a field view in the sense, if you are in this for print analysis, the superior part is actually the inferior part of the patient. But if you have a superimposed multifocal electroretinogram, superimposition against a fundus photograph, that is the retinal view. Otherwise, in this slide, whichever trace arrays are presented here, I'm trying to show if my cursor is viewed. Anyway, I'm connected from my mobile, so my cursor is not shown here. Anyway, at that very middle side, which is colored as red, green, yellow, blue, and gray, so it is the field view. So whichever is shown at the superior side, that means it is the actually is at the bottom of the patient. So see, try to idealize in a way that upper part is a normal multifocal ERG and bottom part is the is from a patient of having anomalous patient. So look at the center. It is well formed, but at the bottom it is not being formed well. It is reduced. So that is what the 3D image is well picked, but here it is completely depressed. It is not being formed. So that is what your multifocal ERG helps us to see, that how the sensitivity of the macula is formed in a form of three-dimensional view. So in previously discussed scenarios, it has its own limitation, it has its own pros and cons that I have already explained, that pattern ERG just does not require to get dilated people. So if your pupil is dilated, better not to perform pattern ERG because it would give a wrong response. And this wrong response, you do not have any clue to understand whether that abnormality is due to the pupil is dilated or due to the pathology is there. Diurnal variation is always present because if you take an impulse in the morning, it may not hold true if you take the response in the evening. It's just like your intraocular pressure, as that gets varied from time to time. There are n number of artifacts. One is the most common is the blink induced artifacts, photomyclonic reflex, that is because that is getting activated from the blink. If light comes and if your patient blinks, then that is related to the muscular tone or the photomyclonic reflex. Artifact can be even due to electrode placement. If you place your electrode improperly, or if your electrode is not good enough to take that record or potential change, that could also give you artifact, give rise to generate an artifact. If your patient is not much cooperative or helping your test, so if you have not make the patient understand at the very starting stage of your test, and if you would have had, but if your patient may not have understood well, that can also create artifact. Media is playing important role. If your media is not clear, if it is opacified or having vitreous hemorrhage, that would also affect that light to go to the retina and from retina to the brain. And as I already have told, your pattern is focusing at the macula, and as well as the ganglion cells which is surrounding the macula, and your full field flash ERG is conveying a message from your global response of your retina. So it is always important that which area, which type of test you are going to perform. So it has its own confinement. So based on that, you have to switch which test you want to do. So these are the further references for your electroretinogram. So you can go ahead and search for further justifications of the routine test and which cases are being well used, which tests are being well used in which cases. So these are the references. Now switching to the electro-oculogram. So electro-oculogram, as I told that in pattern ERG N95, it is coming from the retinal pigment epithelium, but we are not focusing on that much because you already have electroretinogram in hand, so that we can see that health of your electroretinogram. So electroretinogram basically measures the standing potential or the transepithelial potential of your retinal pigment epithelium, that allows you to have a good relationship from cone mediated retinal pigment epithelium and rod mediated retinal pigment epithelium. So it is being done in three stages, in the pre-adaptation stage, dark stage, as well as in the light mediated stage. Pre-adaptation stage is getting activated your cells to get transmitted in between. Dark stage, it is getting a relationship from cones, from rods and RPE, and in light adapted stage, it is getting a relationship, or it is making a relationship from cones and retinal pigment epithelium. So patient should have a good saccadic movement, because if the patient is having an nystagmoid movement or unable to blink or muscular restriction that not allowing the eyes to move, so in those scenarios ERG may not help you further, because it is based on the saccadic movement. Because as in this slide you can see that eye moves from one surface to another, keeping in mind that cornea is positive and your retina is negative. So you have properly placed your electrodes plus minus. If your eye moves, so your cornea goes towards your plus side and retina comes towards minus, so it gives one response. And eye moves from another side, from positive to negative, so your negatively charged ion is more towards your cornea, that gives another standing potential. So it is always important to know that if the eye movement is proper, patient can able to fix it properly, patient may have a good saccadic movement. So that in those cases you can utilize your EOG test. So this is the proper placement of electrode, plus minus. Plus starts from the outer canthus and inner canthus is minus. Again, in the another eye, left eye, inner area is negatively charged, positively charged, and outer surface is negatively charged. So that is what you should have. People may be dilated, may not be, does not react much with the pupillary dilation, but remember patient should at least see the target in order to focus the target and get excited with the saccadic movement. Because unless the patient can see the target, patient cannot able to focus the target throughout the test. So that is no longer your saccadic movement would be activated. This is what a normal EOG looks. It is a saccadic movement that in the left hand side it is the saccadic movements from both the eyes, and in the right hand side it is the graphical representation. The red arrows, the first red arrows coming from the trough, and the next red arrows coming from the peak. So how it is being calculated? It is being calculated as the dark peak and the light peak and the dark trough. So whichever point your light peak is made and whichever trough your dark apex is made, so you have to calculate between these two, and that is what is known as the RN ratio. So RN ratio is the ratio between your maximum peak and the minimum height of your test result. So ideally it should come around 2 as per ISCEV, but it is also considered to be a normal if it is approximately around 1.6 till 1.9. But if it is deviated from this range, it is considered as abnormal. So ideally, it is not done in all cases of having RPE as well as neurosensory damage, because in case like retinitis pigmentosa, your photoreceptors, neurosensory layers as well as RPE all are affected. So it is assumed that your ERG and EOG both will be affected, both will be abnormal. But EOG is aimed in such scenarios when your neurosensory retina is normal or mimicking as a normal, but your retinal pigment epithelium is acting as abnormal. So this is done in such scenarios like West vitelliform dystrophy, where your EOG is abnormal, but you perform ERG, your ERG will be normal or look alike normal. So it is always clubbed this test together if a patient is diagnosed to have West vitelliform dystrophy, to perform ERG followed by EOG or EOG followed by ERG to see whether your ERG is normal or your EOG is abnormal. So it is limited in such scenarios that patient should be much cooperative. It is subjective test, because if your patient does not see the target properly, it does not make the well saccadic movement, your test would be limited. Patient must have to understand how the test is being done. Media should be clear, and in patients that I told that muscular restrictions or nystagmus or not having the good merit of understanding level or less IQ. So in those scenarios, if saccards are not made, then test cannot be. You must not rely on the test. It is useful to see the health of retinal pigment epitheliums, and then you have to have a choice as an electrophysiologist. Being an optometrist, if a patient has come to you, it is in your hand that which type of test you have to do, whether you should do ERG first or EOG, or EOG first then ERG. Then the last segment is the visual evoked potential. It is helpful to justify the understanding of your pre-chiasma because in current days, whichever tests are being used in our daily clinics, that is pattern check reversal, pattern onset, offset, and flash ERG, and those are restricted till pre-chiasma, where the chiasmatic pathway is about to get started. But post-chiasma, it is again highlighted by multi-channel VP, which is not regularly done. So I'm not getting involved this. I'm not involving this multi-channel VP now because it would be a little complicated. So I restrict myself here in these three: pattern check reversal, onset, offset, and flash. So we use a 10-20 guideline. We use to place the electrodes. So because if you do not use your electrodes properly, so your test would be irrelevant, or you can have a more amount of artifacts. So ideally, what is 10-20 guideline? That is you have to measure the areas. You have to have a tape. You have to have a proper measurement. So Nagian, it is shown here. Nagian, that is from the nasal bridge, and another is Inian. Inian is the occipital protuberance. If you go back at your backside of your head, you can see that you can feel that occipital protuberance. That is one bone is elevated. So that is the Inian. So you have to choose that area 20% from your overall measurements. So suppose, for an example, I'm giving you example because it would be easy for you to understand. Suppose you have measured the distance between Nagian and Inian, and it has come around 36 centimeter. So 20% of this 36 would be your Inian for your Inian placement. So that means your that would 10% of your, sorry, it is 10% of that. That means your 3.6 centimeter from your place of Inian, and 20% from your Nagian, that would be around the top of your head where your hairs are about to get started. So 20% of your Nagian would be acting as reference electrode, and 10% of your Inian would be acting as your positive electrode. And the place of your pre-auricular point, that is A1, is highlighted as A1, that is acting as your ground electrode. So again, I'm recapitulating this. Your distance between Nagian and Inian is 36 centimeter. So half of this is considered as a midbrain or CZ, that is known as the vortex. That is 18 centimeter from both the Nagian as the Inian is your vortex. Now, where to put your positive electrode? That is 10% of Inian. That means 3.6 out of 36 is 10%, and 20% of this is going to be your Nagian. Okay, so at the very top of your hair where it is getting started, or 7.2 centimeter, would be your place of your Nagian, and you have to use your reference electrode at the preauricular point or at the earlobe. So it is the overall view that which I have discussed in my previous slide. So it is being translated into a skull model while you try to place an electrode from the schematic view of 10-20 guideline. So if it is not properly placed, what would happen? You usually feel like these noise responses. So if the impedance level is the amount of the noise, if it is not getting excited. So the very first graph is having less amount of noise, and at the bold high frequency bold graphs, which are bold in black and bold in green, these all are the artifacts or noise which is due to the more amount of impedance level. So ideally we should restrict ourselves within less than 5 kilo ohm. If it is more than that, it would create a more number of artifact or create more number of noise. So this is what a normal graphical representation looks. Coming from the beginning, the first one is the pattern check reversal, which is ideally done in daily clinics. It has three options, three components: N75, P100, and N135. So again, this 75, 100, and 135, these all are the implicit times. Usually, N35 comes from the brain, from the retina, and P100 is from the interaction between the prechiasmatic junction from the retina and the brain. And it is not known, well not known where this N35 is getting originated. So there is a lot of postulation, there are a lot of controversial theories. I'm not going into the details, but it is useful in daily clinics where your patient is helping you, well cooperative. But again, it is also helpful to know how your pattern onset offset looks. It is just opposite to just like your pattern check reversal. It is highlighted as C1, C2, and C3. C1 is around 75 milliseconds, C3 is around 100 and 125 milliseconds, and C3 is around 130 to 150 milliseconds. So it is just in overall gross overview, it is just opposite to the what we see in pattern check reversal. So what is the basic difference between these two? In normal cases, when your patient is having some pathology, prechiasmatic pathology, good vision, good fixation, that time your pattern check reversal is helpful. But in the other way, your patient is malingering or pretending to be cannot see anything, or cannot fix it, or having a poor fixation. You have already suspected a case like malinger. So in that time, your pattern onset offset would be helpful, because it does not it no longer rely on the fixation. Now, on the other hand, if a patient is purely having a problem, cannot see well, or it is justified that patient has a problem, so that time your flash VP would be helpful, because flash is only done because while your patient cannot see anything. So it is targeting from the no perception of light till the hand movement or inaccuracy of light, or counting finger very close to face. So in those scenarios, your flash VP would be useful, because the patient cannot see. So it is not well justified to perform something by giving a target. So this test has its own limitations. So this is the normal flash pattern VP looks, and this is the normal flash VP looks. So the upper side is the well repeatable case of a flash VP, but the bottom one is from the abnormal patient. So try to see that in both the scenarios you have two graphs. One is a little shady, one is having a green in nature. So shade one is just to see how your test is reproducible. So how, if you test, what do you mean by this reproducible and repeatable? If I ask you to sing a song in a mode, so we have sung, and next time after a couple of minutes, if I ask you to do so, you will perform this in a same tone that you have already did previously. So that means it is repeatable. So it would not be same for me if I sing that same song that you have made it before in a same tone, because my vocals and your vocals is not same. So if you're performing the test in a same patient in a same row, so reproducible and repeatable should be present. If it is not present, that means your test is not reliable. You should have to perform the test again. So in both the test, in both the graphs, test is repeatable as well as reproducible, but while it's not getting formed in the bottom side of the graph, because the patient is not utilizing the impulse which is being served from the retina to the brain, because the patient has a problem. So limitation again, pattern program relies on the pupillary dilation. If pupil is not dilated, you cannot perform, or if you perform, test report will not be reliable. Patient should have a good fixation, good visual acuity, and you should also give a good correction, best corrected visual acuity. You should have to perform your refraction first prior any electrophysiological test, if the patient has a good fixation and can have, if the patient can see. You should know the guideline to place the placement of your electrodes. If it is not being placed, so your test would not be validated. And simultaneously, that I have discussed in my last slide, that you should look for the repeatability and the reproducibility. So if it is repeatable, despite of the graph is not being formed as normal, if it is repeatable, that means it is good. If it is not repeatable, that patient would have you have any confounding problem. So you have to fix the problem before you start the test. So thank you for your patience, and I hope this online sessions, and in upcoming days your online sessions would be more helpful. And I think these sessions is invaluable to make a good strategy to interact and to upgrade our knowledge skills. Although it is not well phenomenal, because I'm not viewed to you, so I cannot show my eye-hand coordination. You cannot see me. But till, even though these all are the lacunae, but still I feel this is the good initiative. And stay safe, stay at home. If you have any doubt, if we can sort it out here, we can definitely do. Otherwise, Gautam can help to sort this out, because he already had presented a couple of years back. Or else I have my email address here. You can access me anytime from at any time, anywhere. Thank you. Any
Okay.
question?
Yes, sir. Rajan sir, are you there?
Yeah, I'm here.
Okay. Sir, really, does pupil size matter in pattern BEP?
You're asking when to do pattern BP?
Sorry, sir. The pupil size on during the BEP. Really, pupil size matter while we are doing the pattern BEP.
Yes,
Pupil
it does
size will
matter.
on, yeah.
Yes,
Yeah.
it does matter, because pattern BP depends how the patient looks the target. So if you have dilated the patient already and patient cannot see the target robustly, so it is making a image blur. And as the perceptual theory, if your patient is not getting the image clear, it is not being well translated to your brain. So as you know, if your pupil is not dilate, if it is miotic, if your pupil size is not if your pupil size is normal, so it gives you a good contrast, well contrasted image. So that time your pattern VP would be helpful. But if it is dilated, so patient can see the target, but it is blurred, so it is not being translated well, and that would also give impact on your recordings.
Okay. So, yes, Rajan sir, can you please read out question?
So if the discussion is over, then
yes, I
No,
cannot
sir, there is
see.
one question.
okay.
Okay, sir, which type of model VP machine you are using, sir?
Currently, we already had various system that is good for multifocal ERG, because the inventor of various system himself invented multifocal ERG. So that is what various is good. But currently, in our all networks, we are using Metrovision.
Okay.
As well as Metrovision itself is a tabletop, and we are using LKC also, which is acting as a handheld system. So in pediatric age, the uncooperative patients, we can use the LKC model too.
Okay, sir. Sir, okay, there is another question from the Amit Kumar, sir. Hello, sir. Glad to hear you after the long time. Thank you so much for a nice presentation. And he's asking for how to interpret the case of retinal dystrophy by the print.
Well, it is a good question. I have not covered this in my talk, during my talk. So I would appreciate that someone has raised this question. While you have a print copy, do not diagnose the case. First of all, do not never ever diagnose the case. Keeping in mind you have a case of a retinal dystrophy, you try to convey this on your brain, that how a normal graph looks, how a normal ERG looks. Then based on that, theorize how your abnormal graph looks. So suppose you have an ERG report with abnormal findings, then you try to convey this in a way that how this is deviated from the normal, which protocols are abnormal, which areas of these graphs are abnormal. So based on that, you can go more towards whether it is a dystrophy, or the graph is abnormal due to vascular pathology, so on and so forth. But if you have already a case of retinal dystrophy, then correlate that disease and and map this based on your fundus photograph OCT, because your ERG itself is not a standalone test to make your diagnosis. It is always important to look for your fundus photograph, autofluorescence, better if you have your HVF as well as your OCT. So if you have these four diagrams in a row, you can directly correlate. Let's say if you have a cone dystrophy, advanced cone dystrophy, you can see your cone area of cones are mottled on fundus photo. Autofluorescence showed mottled hyperautofluorescence at the center. Your OCT may show absence of photoreceptors at the center subfoveally, and simultaneously your photopic response on fulfilled flash ERG would be flat or abnormal or subnormal.
Okay. Sir, there is always a question for the electrophysiology. It never could be a diagnostic tool as if compared with USG or other tests. So why it could not be a diagnostic test like others?
Yes, it could be a diagnostic case, because in our setup, while as I work here in a tertiary care of LB Prasad, we have been doing the test almost 100 per month. So it is not infrequent, it is being done frequently. It is one of the diagnostic tools. So but the way is, and it takes a more time. It takes a more shared time, because almost it takes around fulfilled flash ERG takes almost 1 hour. So whereas your ultrasound takes only a couple of minutes to get a proper report. So it is only aimed if patient requires that, or if you want to see something more that you do not see on your fundus photograph or direct ophthalmoscope or indirect ophthalmoscope. So that is what it is important, that what you have to see, because in retinitis pigmentosa it is always important to see, because it is important to follow up the case in the subsequent visits. So if you have one ERG, so if patient visits again after 1 year or 2 years or so, so you can compare the test, how it was before and how it is now. So if a patient comes in between, because that change may not happen within 3 months or 4 months, it happens over time. So ERG may not be done if a patient comes after 1 month or 2 months. So that time it is not used as a diagnostic tool, but overall it is a key tool in diagnostics.
Okay. Okay. So if anybody have a question, please unmute yourself and go for the question. Okay. There is one question from the Manoj Mohat. Yes, please. Okay, there is one question from the Manoj Mahat. Thank you for question, Manoj. Since the BAP detects the abnormalities of the optic nerve to the optic chiasma, which is obviously a part of brain, would it better for the patient to go with a BAP test or other neurological test?
VP test is made during the neurological intervention. It is true. Yes, it is. I would agree with Manoj that it's a part of the brain, but we have certain limitations, because as we use some frequencies, restricted band path. So in our regular clinics, we only restrict ourselves to see till pre-chiasma. So there are some neurological disorders which is restricted itself within pre-chiasmatic lesion. So just like NAI vein, so in those scenarios, we should use those pattern check reversal, onset offset, or flash VP based on the visual acuity and the cooperation. But if you want to see, or if you want to map your visual evoked potential on your brain, then you have to switch to multi-channel VP. That would also help you to understand what is beyond chiasma. And it is really little complicated to interpret the test.
Okay, sir. Sir, if certain people have can't focus on the point of the given, uh, so if we have to do the still ERG, so uh, if not passing focusing on the object, this might be a error sometimes. So, is there any techniques like rather than the eccentric or any other techniques that we can record the ERG?
See, if a patient has eccentric viewing, you should not have to intervene if your flash ERG is concerned. You still can go ahead because it is a mass response. But if a patient has eccentric viewing, while you are if you are concerned, if you are looking for some focal change, like in multifocal ERG or pattern ERG, so that time what you have to do, you have to deviate or tilt the head. You have to make your macula parallax with the light being shown. So that is in that case you can perform the multifocal ERG. Otherwise, some number of artifacts can be generated or can be generalized or can be incorporated if a patient would have had eccentric viewing. But it is justified to perform flash ERG, overall flash ERG or the global ERG if the patient is having eccentric viewing.
Okay. Okay, sir. Sir, what is about the ERG recording the patient having the nystagmus?
Can you please repeat the question? Your voice was breaking.
Uh, yes, yes. Sir, what is about the interpretation of the ERG reports patient having with the nystagmus?
Okay, good question, Gautam. If the patient is having nystagmus, still you can go ahead with the test, but you should keep in mind that which type of electrode you are using, because there are certain electrodes which extrapolate the response if the patient is having nystagmus. Just like let's say DTL electrode that is placed at the outer canthus and just goes from the bottom of the cornea, or the LVP electrode. But if the corneal electrode, just like jet electrode or Boolean electrode, if that confirms over the cornea, your test result would be better compared to your non-corneal electrode. So in that time, what you have to use is you have to revisit the test again. You have to redo the test to see the response, because in nystagmoid cases you will have a more number of noise, more number of artifacts, because your eye is not static, it is moving against the electrode. So you could face an extensive amount of artifacts throughout the test. So what you have to do during the test, best possible way to get a good report, less amount of noise, is to get a proper null point. So how to make a proper null point? You have to deviate the eye surface prior to insert the electrode and see the null point. Where is the null point? If the null point is at the conventional area, or you can comfortably perform along with the patient, if the patient can cooperate during the test, then it is good. Otherwise, if your null point, if you have found your null point but it is very hard for you to perform the test, then go for the best possible best possible way to get the near null point area, then perform the test. In that sense, you can still have amount of artifacts, but that number of artifacts would be lesser than the normal artifacts that is being seen in nystagmus case. So first try to get a null point. If you cannot get, then go to the area where eye movement is almost a little less compared to the exaggerated movement.
Okay, sir. Okay, please.
So
If
I
anyone
have
has
a
a question.
Hello,
Okay.
am I audible?
Yes, yes, sir. Yes, Sati, sir.
Yeah. So it was a nice presentation. So
Okay,
I have a
thank you.
question regarding multifocal ERG. So while performing the multifocal ERG, do we need to dark curve the patient?
No, in multifocal ERG, we should not have to make the room dark. because as I told, it is cone mediated. It is more towards the bipolar cells and ganglion cells. So dark room is not required. It is not mandatory.
Yeah, in clinically we don't do that, but if we are doing some research for research purpose and all, so if we want to evaluate the rod functions as well, so can we dark adapt and check?
It is a tricky question, because you should, if you are looking for the photoreceptor rods, you have to use your if you have to use the principle of multifocal ERG. Suppose you have made the room dark and you are doing the multifocal ERG, you are still using that 75 hertz of light in front of the patient, so you're not activating your rods. You're still, your cones and cone mediated areas are activated. So it does not matter if your room is dark or room is well lighted. So you cannot even see any rod mediated response from multifocal ERG, Manoj. But if you still want to see something, you can go ahead. But what I feel from my view, what I sense it in a way,
not useful.
Clinically, you no, I'm not talking about the clinically. I'm talking about clinically as well as in research basis, because if you have made the room dark and your Gans field is well lighted, so there is no way your rod can be activated. So there is no point of making it in a research basis to see, look for the photoreceptor rods, but just by making the room light dark, because there is no point of activation of rods in through multifocal ERG.
Okay. So next question is in multifocal ERG, the stimulus array, it has hexagonal pattern. So why it is hexagonal? Why not other shapes?
Yes, it is very conceptual question, Manoj. Hexagonal pattern is taken from the density of the cells. So as you see that while you interpret specular microscopy, you would have seen that your cells are always hexagon. So cells are always hexagon in a way that it is not populated in a particular area. So hexagonal size is more concentrated at the center just because of the amount of cones. So it is one, and second is amount of population of cell in a particular direction is not possible if you have made it at the hexagon. But if you have made it triangular or square or circular, so it could be populated in one particular direction, and it could be elongated later, and that could involve that could make one impact while you interpret the multifocal electroretinographic response. So that is what hexagonal response is principle. It is theorized since starting from the beginning.
Okay, so it is to properly stimulate and get the response from a cell.
Yes, because it is not populated in either way if it is well hexagonal.
Okay. And you told like there are handheld electrophysiological devices also available. So are they equally reliable?
Yes, good question. Again, good question. So these handheld devices, as it is good for to intervene such patients where those patients are not helpful for the tabletop machine, yet those machines are not well reliable, because you do not have any option to measure the response manually. Because in Metrovision varies in tabletop systems, you have options to manually calculate the waveforms. But in handheld system, it is not there. First, and second, the electrodes which are being used, those are skin electrodes. So as you go away from the cornea, your amount of response would also come down.
Okay.
Any further questions?
So if they are not reliable, so we can't use it clinically, right? Clinically or for any research purpose, it's not good to use.
No, you can still use, because see, that comparison between tabletop and handheld is already made. But you can still use, suppose for an example, you are doing some study in a patient who are operated in operating theater. So that time you cannot take the handheld tabletop system in the OT and can perform the test. It is not possible. So in those systems, as you have your normative data for tabletop and handheld device, so you can still perform a study, because your handheld, you should have your own normative data that should not be equal to your tabletop. Handheld and tabletop should have its own normative data. So if you're doing in a patient group like a malingering patient or uncooperative children, then in those time you should use your handheld system rather than using tabletop, and can use your own theory, and you can use your own conceptual theory and can perform and can go ahead with the study.
Yeah. Okay. Thank you so much.
Yes, it is good to have such questions, because in those we can interact much, and we'll be switched to the next level. We can discuss basic to advanced. And that is always and that I appreciate that you have a lot of questions.
Okay. Sir, what about the color vision? Does ERG helps to color vision patient?
Yes, it does. Because if you see some patients having cone dystrophy patient, if you are performing tests, if it is advanced, color vision and ERG both will be, but you should always correlate. It is not true, it does not always hold true that if a patient is having a partial color vision loss and your ERG is abnormal, it is not possible. Your ERG still can come as normal, but you should correlate always if your color vision is affected and how your ERG is deviated from the normal. Does that answer your question?
Yes, sir. Yes. Richard, sir, are you there?
Yeah, okay. Yes, I'm here. Yeah, okay. I think we're almost at the end of the session, and first of all, I would like to thank you, sir, for coming up with this wonderful session. And it is really a good, it is really a privilege for us to have you in this session. And now I'd like to request all the attendees to fill the feedback form and spare your 2 minutes to fill the feedback form, and it's on the chat box.
Yeah, I'm also
So please,
privileged to get this platform, and thanks to you to get me involved. Okay, shall I have to do anything from my end, because I'm connected from my phone, so I cannot see my chat box even.
Okay, sir. Okay, I will be sending from you in WhatsApp. If you go to the message box, you can find there, I guess.
Yeah, I'm trying. Yes, yeah, I can see. Should I have to do anything from my end?
Sir, it's only about. Can you please we have read some international electrophysiology society files and the Byron electrophysiology. I have known these two books. So rather than these two books, do we have other best book that we can follow?
Yeah, true. There are a lot of your electrophysiological ebooks are available. You can always go there, just like a Miyake or Shepherds or else. What I can do, I can WhatsApp you some of the books, good electrophysiological ebooks which are available online. You can go ahead and if it is possible, you can download too.
Okay, so there is one question from the Anup sir. So what is the electrophysiological role in early detection of glaucoma?
Yes, in glaucoma, it is more about affection of macula as well as in ganglions. So your electrophysiological test, certain electrophysiological test would help you to understand what is the health of the or the what is the function of these particular areas, just like a macula as well as the ganglions. So you already know that macular RNFL, ganglions and photoreceptors are getting involved or getting affected during glaucoma, or in advanced glaucoma these all are done, all becomes apoptosed. So your pattern ERG and pattern VP is usually done, and there are some advanced protocols which are being done to look for those to get picked up by the electrophysiological test.
Okay. Okay, hope Anu sir get that answer. All right. So if you have any good notes to us after the end of the session,
Yes, my good notes is that is what I kept on asking Gautam yesterday. Then how many are getting connected, and who all are they? And based on that, I have to prepare the presentation, because it is possible that most of you are having online session, and in recent days I also do have my online sessions. So I planned that better to go ahead by today itself, because do not know what would happen tomorrow or day after. So good note here is that I have inter backgrounds here, that few of you are already faculty working in Nepal, and few of you are working as a professional optometrist here and in India, or students acting as a students. So it is always good to have to get interacted with you all and getting accustomed with, and this interaction and this interacting session would be always helpful to increase our fundamental dilemma. That fundamental dilemma is what to do. Should I have to approach that, or should I have to approach those things? Which one is good, which one is bad? So this fundamental dilemma, I also know that this is more towards opthal part, because opthals are mostly used to with this electrophysiological test. But keeping in mind, I would survey this message that you can be a good electrophysiologist if you are in this background. So you can at least understand how your retina acts, and how the transmission is getting it taking place to the brain. And there is a possible outcome from the neuroscience, that how the visual electrophysiology is helping us to see. So this electrophysiology and accommodation and depth of vision, depth perception, stereopsis, these all are interlinked. So it is always interlinked. So if you know this physiology, know the principle, you can interlink this all in a same frame. So that is what I would acknowledge, that is a good platform, and I appreciate this session. Especially I would thank Rohit from LVP, and as well as Gautam to coordinate the session. Otherwise it may not be succeeded in to perform this session. And I have my colleague here. I guess he is available now. He is online. Is Utpal. He is also from LV Prasad.
Okay.
From Nepal.
Okay. Tutkal sir, are you there, sir?
Thank you.